from Professor Barbara Casadei, and it's on the STICS study.
Good morning, and thank you for giving me the opportunity of presenting the STICS trial. STICS was an investigator-led study that was funded by the British Heart Foundation mostly, and other charities and agencies, and we also received an unrestricted grant from AstraZeneca, which is my declaration of interest that is written in here. It was the fruit of a collaboration between the Clinical Trial Service Unit and the Department of Cardiovascular Medicine of the University of Oxford and the National Center for Cardiovascular Diseases at the Fuwai Hospital in Beijing, in China. So the coronary artery bypass surgery we know remains the standard of care in a reduced but still substantial number of patients with ischemic heart disease, as you would have seen the guidelines that have been presented at this meeting. And despite improvement in both the surgical techniques and the perioperative care, postoperative complications, and in particular myocardial infarction, atrial fibrillation, and renal failure, are still very common, involving about 35 to 40% of patients, and are associated with increased mortality, disability, and cost. So particularly, postoperative atrial fibrillation is associated with a twofold increase in stroke and mortality in the postoperative period, and a contemporary analysis of the cost associated with these complications have put it at around at $8,000 to $18,000 extra for each patient undergoing cardiac surgery. So because we know that inflammation plays a big role in these complications, and we also know that statins have pleiotropic effect that are short at starting, there has been a substantial interest in the use of perioperative statins in these patients with the hope of preventing postoperative atrial fibrillation as well as perioperative myocardial damage. And the results of these small clinical trials have been really staggering, showing about 50% reduction in postoperative atrial fibrillation with just 2 or 3 days of statins before surgery, as well as prevention of heart muscle injury, myocardial infarction, and in some cases even postoperative death. However, we figured out that there were several limitations to these previous trials. In particular, all trials were quite small. We have just updated a meta-analysis of them, and there are only about 1,300 patients in 14 trials. And there are methodological problems, in as much that many patients in these trials were excluded. The trials were only done in statin-naive patients, which is not really so relevant for common practice. And in some of them, patients with atrial fibrillation were not excluded, so making the really assessment of this quite difficult. So the outcomes were not assessed systematically and or not always in a blind manner, and the analysis was not always by intention to treat. Similarly, some selected results were emphasized retrospectively, that is, that atrial fibrillation was not an aim on a main outcome of these trials, but there was just an ancillary finding. You know, we looked at that, and by the way, we also report atrial fibrillation. So because of the implication of this and the fact that if positive, this could be almost a separate indication of statin treatments in these patients and also other patients in whom atrial fibrillation is triggered by inflammation, we thought that we needed to undertake a larger randomized placebo-controlled trials of perioperative statin where we would assess these outcomes systematically. And this was STICS. So STICS recruited 1,922 patients in sinus rhythm and no history of atrial fibrillation, awaiting elective cardiac surgery. It was, of course, a double-blind randomized trial of rosuvastatin, 20 milligrams daily versus placebo. And the treatment was started up to 8 days before surgery and continued for 5 days after surgery. So the main outcomes were postoperative atrial fibrillation as assessed by a 5-day Holter ECG and myocardial injury that was assessed by serial troponin measurements. And we also looked at other major clinical outcomes and determinant of costs, such as intensive care unit stay and in-hospital stay. So if we go to the first outcome of atrial fibrillation, and this is depicted in a conventional manner, so with the odds ratio, rosuvastatin better here and placebo better on this side, you can see that 21% of patients on rosuvastatin had postoperative atrial fibrillation, 203 events, versus 20% in the placebo. So an odd ratio of 1.04 with a p of 0.72. So overall, there was no effect on postoperative atrial fibrillation. If we look then at predetermined subgroups, for instance, did it make a difference whether the patients were on statin before surgery or not? Because because the study has recruited in China, then we had only 35% of patients who were taking statin at the time of surgery, so we could do this analysis. And you could see that it didn't make any difference. Similarly, patients who had non-steroidal or steroidal anti-inflammatory drug after surgery also did not affect the impact of rosuvastatin on atrial fibrillation, as you can see here. Similarly, whether patients took the randomized treatment for about 2 days or more than 2 days before surgery didn't make a difference, or whether the surgery was on pump or off pump. So if we go through the second main outcome, which is troponin and cardiac muscle injury, again, we did not reproduce the previous results, and we did not see any difference between the placebo and the rosuvastatin treatment. Again, the p is 0.72, and there is only about a 2% difference in the troponin curve between the two. And similarly, if we look at all the subgroup analysis, in this case, there was no difference, and I'm not going to show it to you in the interest of time. So in summary, STICS recruited more patients than all other trials of perioperative statin in cardiac surgery combined. And the outcome in this trial were meticulously collected. So what we can conclude, nevertheless, is that intensive perioperative treatment with rosuvastatin had no beneficial effects on postoperative atrial fibrillation, on heart muscle damage, and also other complications after cardiac surgery, including myocardial infarction and the duration of stay in hospital and in intensive care. So preoperative statin use, the type of surgery, postoperative use of anti-inflammatory drugs, the time of initiation of the randomized treatment had no bearing on the results. So the conclusion is that there are many reasons why these patients should be put on statin treatment, but the prevention of postoperative complication is not one of them. Thank you very much.
So, Professor Casadei, we've got time for questions now, and I guess this is a reflection of the importance of having an adequately powered, robust study to answer this question.
Yes, we were powered to to detect a much smaller difference in the outcome than those that were previously reported. We could detect a 20% difference in troponin with more than 90% statistical powers with the p of 0.001.
So from your perspective, this issue is closed?
From my perspective, it is, yes.
Okay.
I think this is the definitive answer. In this population, yes.
So it's important for us to have definitive positive as well as definitive negative.
Yes, I mean, of course I didn't start the study
with that in mind.
with this result in mind, but nevertheless I thought it would be important to have it. I don't want this message to get mixed up with the need of treating these patients with statin for long-term for the long-term effect of lowering LDL cholesterol in these patients. But for short-term effects, I think this is a little bit of the end of the pleiotropic effect of statins in terms of having an impact on clinical outcome. They are there, but they are not impacting on outcome.
Please, and if you don't mind just saying which publication.
Ed Sussman at the MedPage Today. Is there any rosuvastatin is considered probably the most powerful of the statins available. Yes. Is it possible that you overdose the patients and that other statins in lower doses might have a better outcome?
Thank you for the question. I mean, in the previous studies, the effect was consistent across a wide range of statins and doses. In fact, there are two previous studies on using rosuvastatin that show more than a 50% reduction in the troponin curve, for instance, with the same dose. So we did see already at 48 hours post surgery, a reduction in LDL cholesterol in these patients, and we had a compliance of 98% at the end of the trial. So I don't want you to think that this is negative because they didn't take it or something strange happened. There was certainly an inhibition of HMG-CoA reductase, but it just did not.
And you're convinced that this is a class effect for the statins?
Yes.
The gentleman behind you.
Hi, I'm Michael Reardon with theheart.org. I guess this closes the door on statins to reduce inflammation in cardiac surgery, but are there other studies ongoing or any plans for other studies that looked at reducing inflammation in the cardiac setting? Well,
there have been previously published studies using steroids in the perioperative period. So interestingly, as I said, the patients were recruited in Fuwai because we wanted in a large center that we recruited all of these patients in 2 years. And they have, we've discovered the practice of giving patients a shot of steroids in the post-operative period. And at the beginning, we were very concerned that this would interfere with the effect of statins. But if you look at the analysis where we looked at patients who had it and patients who did not, that kind of shot of statin did not make any difference on post-operative atrial fibrillation again. So, I mean, the inflammation is there. There is a strong association in animal studies and in other studies between inflammation and postoperative atrial fibrillation, but whether the association is causal, I think is still debated.
So we're going to be coming back to the issue of steroids after Professor Mayosi's presentation, which is the last of the presentations in this